decision making. So I'm going to speak about what we mean by public health modelling and the impact on public health policy. And then I'm going to give an overview of historically how modelling has been important in healthcare decision making. Then talk about the current state of modelling, and then finish with some future challenges. I think a lot will overlap with what's been said in the previous talks. So just to give a disclaimer, I'm sure everyone has their favourite policy-related paper, and I'm probably not going to cite it, so apologies in advance. So it's really from a personal perspective. So my less sexy headings for the sexy versus utility combination is distal impact and proximal impact. So when I'm talking about the distal impact of models on public health policy, I'm really talking about a lot of the kind of mechanistic modelling that's been done that we've heard about today, which are able to explain phenomena and estimate parameters. And these are exceptionally important in order to sort of propose strategies and to motivate more data collection. But few rarely see the light of day in actually the impact on decision making, which is where I'm talking about the proximal impact of modelling, which is perhaps the utility, high on utility, perhaps low in sexiness. So these are models that are able to predict effectiveness of strategies, and they're often combined with a cost-effectiveness evaluation in order to directly provide evidence to policymakers about a set or a suite of interventions and what to pick. And of course, because it's always an iterative process, both in modelling and science, a lot of these strategies that we've perhaps uncovered from the 70s, 80s, 90s, 2000s, then lead back into a suite of hypotheses that we can then predict the effectiveness of, or perhaps a new vaccine comes into play. So a lot of people in the audience will know what cost effectiveness is, but for those who don't, I just want to give a minor detour just to explain what we mean by cost effectiveness, because it's terribly important in transferring modelling decisions into actual policy, at least in the UK. So what do we mean by cost effectiveness? Well, I'm going to be talking about a given disease for a specific intervention. I'm going to be talking about the UK decision-making process. Because cost effectiveness is particularly important in the UK, each nation might have their own criteria for decisions. Okay, so we're talking about cost effectiveness, so we need a measure of costs and one of effects. So the effects are usually measured in QALYs, which I'll mention in a bit more detail on the next slide. So these are quality adjusted life years. So in principle, and this is where modelling is so important, we understand the sort of status quo, so what we have with no intervention. And we can estimate the clinical care burden that leads to costs, and then we can simulate our model with an intervention in place to predict, if you had the intervention, what would be your reduced clinical care burden. But you're also going to incur costs from intervention prices, so the vaccine price, for example, and the administration. So we want also a measure of effects, and so we want a loss of the quality of life. So this is all on one scale, being able to combine the effects of morbidity and mortality into a single unit of measurement. So with the dynamic models, we're able to predict the effect of the reduced loss of quality of life with your, for example, vaccine or new treatment in place. And if we calculate all of these things from a dynamic model, then we can get to our ISA, which is our incremental cost effectiveness ratio. So this is how much you have to spend to get 1 unit of 1 unit of life, effectively. So QALYs are, as I said, quality adjusted life years. So it's a utilitarian approach for measuring health outcomes in order to transfer results from a dynamic model or a static model into measurements that policymakers can use. So it's a utilitarian approach because it's based on a preference scale where 0 equals death and 1 equals perfect health. So let's just have a look at a few examples. So in the first instance, there's an acute illness that lasts for 1 month where your quality of life is reduced to 0.6. We're also going to look at the death of an infant and also the death of an older person. So in the first case, where you have an acute illness, you're going to lose 0.4 quality of life for 1 month. And so if each of these people is a unit of a month, then over the course of a year, you've lost 0.31 QALYs. So you can do the same thing for if you want to look at the QALYs lost for the death of an infant. If you have a life expectancy of about 80 years, we're going to weight the first years of life more heavily because we're looking at it from an economics perspective. And I'm not going to go into discount rate, but you apply effectively a discount rate, so you care more about what's happening now than what you do in the future, because if you weighted everything equally, you would always delay your decisions. So the death of a baby would equal about 27 QALYs using a certain discount rate and assuming perfect health for all years. We do the same for the death of an older person, and we get to 8 QALYs lost. So that's what we mean by cost effectiveness. So this is a way to put everything on the same scale, so we can, in this example, the death of 1 baby is equated to about 900 acute episodes, or about 3.5 older person deaths. So once we've got this, we've calculated our incremental costs and our incremental effects, then we can plot everything on a cost versus effect axis. And for the UK, we can calculate if the ISA is below a certain threshold, then we're into the very cost effective or cost effective regimen. If we're above that threshold, then the intervention is deemed to be not cost effective, which provides evidence that we shouldn't probably be implementing the new policy. So back to flu. So we've had 5 pandemics over the past century, and these have been concomitant with new pharmaceuticals. We've had antivirals and we've had vaccines. And on top of this, we've had policies. So just highlighting a few important policies, the WHO have taken stands on various things such as vaccine composition, as well as which target groups to vaccinate. The ACIP, which is the US equivalent of the JCVI, recommended after the flu pandemic that everyone over the age of 6 months gets the vaccine. And then I think an important milestone, both in terms of policy for the UK and the effect of modelling for policy, has been the initiation of paediatric flu vaccine in 2013. So all of this has been happening, and I picked out a few kind of, I think, key modelling papers. So the Michigan population studies aren't modelling, but they've really motivated a lot of how we think about target group vaccination, and motivated the early models. So the early models I'm really seeing are the mid to late 70s. Excuse me. It's starting with Elverbeck, and Longini, which they use mechanistic models of flu. So we really jump, and I'm going to mention Elverbeck in more detail in a minute. So we jump really from the 70s. In terms of impact on flu policy, we really have to jump to the 2009 pandemic. where for the first time with flu we saw an opportunity for real-time modelling, which was really a huge advance in terms of modelling making an impact on policy, or rather having the potential to. And then finally, Mark's model, the integration of the dynamic model with the cost effectiveness, which was intrinsic to the decision to introduce paediatric vaccine in the UK. So I'm going to give two case studies. The first one is the original 1976 American Journal of Epi paper, which used an influenza simulation model. It was an individual-based one, and this just shows the flow diagram. So these were people who were modelling individual people in their work, in their school, and then modelling the flu progression. So I really think that this is a sort of pivotal paper in terms of methodological advance as a public health tool, for four reasons. Firstly, because it was influenza specific, they model the Hong Kong and Asian strains. They also stratified by targetable subgroups, so individuals, families, households, neighbourhoods, schools. And although they don't give a huge amount of justification, I find this sentence kind of hilarious, that this is the only thing they said about their model fitting, is we have found a set of parameters that gives satisfactory agreement to the data, and left it at that. But the fact that they did this was kind of amazing. They did it in lots of different places across different ages. So they saw the need to stratify, this is in the late 70s, the need, and they implemented it. And we've been hearing a lot about using multiple data sources. So there was no sophisticated statistical modelling techniques back then, but they had the foresight to use different data sources in order to calibrate their model. So a lot of what they've done has really been the sort of bread and butter modelling that we think about today. So I think it's really a prototype model for public health decision making, because the results that they present are very pragmatic. They look at different coverages, they've looked at different the timeliness of vaccine implementation in order to get, these are attack rates for various groups. And although they didn't use a cost effectiveness analysis per se, I think they were quite forward thinking in their approach, because they gave efficiency calculations. So for a given coverage, they were able to calculate how many cases by age each vaccine dose would avert. So you can very easily tack on a cost effectiveness analysis based on this work. And they have a long discussion at the end. So the application to public health is very important in terms of translating their model results into implementable strategies. So this is in the 70s, and I really feel that it's been quite a slow start for modelling as a public health tool. If people were doing this back in the 70s, we're only seeing now in the sort of 2000s that this has really been taking it off as a way to really think about policy decision making. So moving to more the current day, I wanted to mention the work done by Mark and AJ during the 2009 pandemic. And so they were fitting a model in real time and using serology, incidence data, and also the severity assessments that we heard about before in order to fit the model and to understand what was going to happen in the second peak. And I think the reason that they were able to do this was that the school closures that allowed the tapering off of the first wave to happen gave them the time in order to do a very nice job at fitting the second wave and understanding the implications of vaccination. So they not only did modelling in real time, they also did cost effectiveness analysis in real time. So they were able to look at various different vaccination strategies in order to provide evidence for policymakers whether or not to introduce a vaccine above and beyond the risk group populations that were most at risk for severe outcomes. So you can see quite clearly from this figure that on the left-hand side, where you only target the risk groups, it lies low, below the cost-effectiveness threshold, and the second and third bars lie quite clearly far above the cost-effectiveness threshold. And so their conclusion was that vaccinating anyone other than the risk groups is likely not to be cost-effective because of the lower risk of severe outcomes, but also because of the very pragmatic problem that the vaccine rollout would take much longer in the case where you're targeting a very large proportion of the population. So looking now to what's going on currently. So we've heard quite a lot from Anne about model fitting and evidence synthesis. And I think that's really an area worth stressing again. The amount of knowledge that we have from quite robust and complicated model fitting techniques that weren't around a few decades ago. So specifically using Bayesian frameworks to confront models with multiple data sources and to re-estimate parameters. So I'm just going to show Mark's results again from 2013. So the interesting thing, I think, moving back to what John Reed was saying earlier about implementing, so for example, like contact matrices into models, the evidence synthesis approach not only allows you to take the contact matrix structure as your as information, but it allows you to take it as a prior. And so Mark's model nicely shows that your contact matrix will subtly change when passed through all the other information. So this is really a very nice way of doing what models do best, which is sort of inferring things that we can't directly measure. And so the graphs on the right are also examples of this, so moving your prior to your posterior and updating your knowledge about what we know about flu epidemiology. And so this sort of leads us on to quite a sort of practical point, which is this robust model fitting really allows us to understand that we can use this open source software for modeling in general. And so there's been a sort of emergence of new open source software, both open source software and just binaries for being able to run models using a downloaded suite of methods other people have developed. So this really kind of cuts down on the time and someone's done it, you perhaps don't need to reinvent the wheel. And I think this really nicely illustrates. So these are examples. So there's Anton's model that he used to fit the Ebola models to in the middle, and a few other recommendations. And so Mark and Edwin's flu of evidence synthesis is our package on the left-hand side. So by incorporating this kind of this new wave of software, we can really have, I think, additional policy impact because we can more easily focus on the policy questions and get less bogged down in a way for more people to be using robust software that other people have created. So on that note, I'm just going to mention the policy, the modelling work that we're currently doing based off the evidence synthesis code that Mark and Edwin have been developing. So we've been taking this very difficult to parameterize model and asking quite easy policy questions that would have taken us so long to do had the framework not been set up prior to us coming along. So this is some work in progress. And I'm just realising that Edwin's name isn't down here, so apologies, Edwin, sorry. I must have got left off in my haste yesterday. So this is looking at the cost effectiveness of the elderly flu programme when you have a paediatric programme in place. So at the bottom, we're vaccinating the toddler, the primary and the secondary school kids, and we're asking, given different coverages of paediatric vaccine, how cost effective is your elderly program. And our conclusions are probably not very. If you're getting good coverage akin to something like you're getting in the elderly population, so about 70%, if you manage to increase your coverage to the level that the infants are being vaccinated in their primary schedules, then we're thinking that actually the elderly vaccination probably isn't cost effective. So this is work done really based on the abundance of good, robust model fitting available to us. So real-time modelling, I mentioned that before, but just to say this is really, historically, I think the precedent was set during the foot and mouth crisis, where the government commissioned multiple groups to be working on looking at very politically sensitive interventions in real time for the foot and mouth crisis, and then has subsequently been used for obviously the pandemic flu and also the recent, or actually now, as of today, I think, eliminated Ebola crisis. So finally, and I think John did a great job of discussing this before, so I won't really say much about it, is the importance of large-scale social data and the challenges that we face in modelling in order to incorporate this in a really meaningful and implementable way. And so this is just a screenshot from the Netherlands flu survey. So I'm going to end by talking about some challenges. So we have fairly kind of run-of-the-mill challenges in terms of modelling public health. So I really feel like these are sort of high utility, low sexiness. We've got new formulations coming out. We have the question of tri versus tetravalent vaccine and the promise of somewhere in the future a universal vaccine. So we need to put all these new interventions through the modelling framework at some point. So modelling also comes hand in hand with cost effectiveness analysis, and so we need to think about intelligent ways of integrating models and cost effectiveness analyses, integrating lots of effects that we don't usually integrate. So for example, non-specific effects. So Lula mentioned this before in terms of co-infections, so we can have both beneficial and deleterious effects of co-infections. Another important and quite burgeoning field is looking at antimicrobial resistance and the impact of increasing flu vaccine coverage in order to mitigate antimicrobial resistance, or rather prescribing as a proxy for antimicrobial resistance. And finally, we've heard quite a lot about social behaviour. We know that vaccine uptake is fairly poor. We know that human behaviour is very difficult to quantify, and there are actually a suite of models called economic epidemiology models that really try and look at the impact of human behaviour on epidemiology. But these are really quite theoretical models, and I think it would be very fruitful in order to try and face these existing models with behaviour and choice data that we're seeing coming out from a lot of these large-scale studies. So I thought I'd end by also talking about the challenges in modelling, not necessarily just for flu, but in general, in order to have more of a public health impact. And so I've mentioned this, this idea of open source software being increasingly important, and I think maybe as a modelling community we need to think about our model for our sort of business model, if you like, for understanding how these models get into the public domain. So I think bioinformatics had a long history of being able to publish a standalone piece of code, and I don't think that's usually the case, or hasn't usually been the case in modelling, which usually relies on results-focused publishing, and I think it would be very nice, and I think we're really seeing this over the past couple of years, to try and get published just based on your code alone. So you actually have some nice, robust software that people can use. there's just a general challenge regarding the accuracy of our predictions and really how we can integrate these contact matrices and sort of use models strategically to fill in the gaps that we don't know. And I think the evidence synthesis is going to be very important in this regard. And finally, it doesn't really matter how good our models are or our fancy cost-effectiveness analysis or our sexy graphs. If we don't produce results that policymakers can understand or they can't interpret, then we're kind of wasting our time. So the onus is both on us and hopefully the policymakers to improve sort of the statistical understanding and also to be able to translate our results more effectively. So I just nicked this slide off Stefan before. So I've really been talking, you may remember that Stefan partitioned our knowledge into these sort of three areas. So I've been talking about this little, I don't know what that shape is, but it's this little bit in the middle. And I think that has really been quite a slow effort. You know, that hopefully, well, I would have thought incredibly influential papers in the 70s. We're now only implementing paediatric vaccination in the UK in 2015 after many modelling studies in the past said it was really beneficial. So I think it's been a long process. But all the models that are coming over the past few years are hopefully testament to how this field is really emerging and how important modelling is going to be in the future. So I'd just like to thank my funders and PHE for hosting and Mark for doing such a great job in organising this symposium. So thanks, Mark. Okay, thank you.
I think now we can take a question specifically for Katie's talk, and maybe we can have maybe people are a bit tired with all these talks and the hot room, but we can have a session of maybe discussion questions, and when we bored of being inside, we can go outside and we can maybe meet up for a drink at a pub nearby and keep on the discussion. So first, the question on the talk from Katie. So any questions?
Thank you for a nice talk. Interesting. You're telling me what's called the open or freely available software for the public health. What is what is the idea behind that one? Because even the software we are paying the what's called in cost highly, which goes rigorously through some standard check or whatever. For complex model, two different people, if use the same data, they will end up getting different result. Mm-hmm. Because complex model needs a little bit high understanding of modeling. Yeah. For example, you're talking about MCMC. Mm-hmm. How are you going to put this one open resource software to people understand and apply it in the PHE? They need a really highly skilled people at PHE sitting there. And if something goes wrong, and then try to understand where it did go wrong.
Yeah.
I will let Katie answer first, and I think Thibault probably want to add something.
Yeah, thanks for the question. Yeah, it's a very important question, and it sort of, I guess, alludes to what I was talking about in terms of sort of business model for how do you approach putting out software into the world. First of all, I think that it's very important. We have obviously a peer review process for papers, and then we have a citation index, which gives some indication of perhaps the quality of the paper. Give or take various other factors. But we're only just starting to have that for open source the software in general, usually open source. But And so I think there has to be some sort of a review process that takes place, which will hopefully converge on sort of weeding out the wheat from the chaff as far as good algorithms and bad algorithms. So I think that comes sort of half the way to the question that you're asking, because it's being able to separate what algorithms we should be using from what we're not using. But then there's a sort of perennial question of end users. We're not usually software engineers. We've been hired to do modelling, and I think there's becoming increasingly a kind of a difficulty between implementing software for your own use and implementing software for another person, or rather writing code. And I don't really know the answer. You kind of need, if I talk to friends who are software developers, I'm embarrassed because I don't unit test my code. I don't do all these things that's so normal in the sort of software engineering field, that specifically speak to your point about you getting a transferable bit of code or program that people can actually use. And so I think we've got a long way to get things up to speed, if we want to get up to speed, or maybe we don't. Maybe we don't want people tinkering around with MC code that they don't know what they're doing. And I would argue that perhaps there is a level of user friendliness that we perhaps don't want. If we are going to be making very important decisions, we'd perhaps want people to be completely understanding the code and the methods behind it. I haven't really answered your question, I'm sorry. But
I don't know, Thibaut, do you want to add something?
Yeah, it's a bit of a jest, but I would say the difference between open source and non-open source is if it's broken in open source, you can fix it. If it's not, you're screwed. And I would even go further, saying that the more complexity there is, the more transparency there needs to be. And we need to distinguish between open source, you can access the code, so it's transparent, which for scientific purposes, I mean, we're talking about reproducibility, etc., so that's probably a good thing. Being user-friendly is a completely different thing. So you can have, like, user-friendliness is orthogonal to being open source or closed code.
No, I totally agree. I mean, open research for scientific research is fantastic. You go to the art. I'm coming from the academic background, so yes, I agree with open source. But the trouble is, those complex models, you're dealing, the individual people, the statistic or mathematical understanding when they're applying the data, it is just, they're following what's the software is offered. And if you just simple model, you just model different way, you will get different answer. I can show you just here, for example, we have a Stata software, which is, we're paying, and it is, a little bit tested by, rigorous policy. But even in the text, they are written the text, there is wrong over there is fault over there. It is for simple model, classic regression or whatever, fine. Any resource information you're using, you will get more or less the same answer. The difference is minimal. But for complex model, you will end up getting really, really different answer. Policy is effective against policy is not effective. This is not coming from from simple model. Simple model will give you the same answer.
Well, I think it's probably more easy to detect for reviewers or JCVI committee members or whatever to detect errors in simple code, because you know that if you have a very, very simple code, you can perhaps intuit what's going on, whereas complex models are a bit of a black box. I wouldn't say the error is easier to make, they're just perhaps less easy to find.
That's partly something which I'm driving a lot of.
Can I just a brief comment on that? I think the best review process is the community, and if there is a piece of software where there is buy-in from the community, something like the way they use Beast in genetics or something, which is commonly used, I think that's the best faith you can have in something. And also, I think just a brief comment to what Thibault said earlier. I think actually, to me, open source and usability is not completely orthogonal, because I think having your code transparent is not only about making it public, it's also about making it accessible and making it readable and allowing people to understand it, because if it's so poorly written that it's a black box, then in the end there's not much benefit from it being open as such, I think.
I'm not sure if there's any other question for Katie on model and policy. And so, I mean, it's still relatively early, so I think we can take time if you have any. I mean, I don't know what you get from these talks. I mean, and I understand that you're from a different background as well, so that might have resonated differently depending on where your background. I mean, I haven't really thought about how to lead the discussion, but do you have any question that you would like to ask for any other people from previous presentations, or?
We get a chance to think about it.
Okay, so shall we go to outside right now? Okay. So I propose to just join all together. With a nice pub, Sushando. So John, or people who have been there for a long time ago, seems that it has changed quite a lot. And we can just, so if I want to join, we can just try to meet up together and to try to discuss a bit about the presentation. I guess all the speakers will come, so with a chance to ask for direct questions. So I would like, to conclude this series of talk by thanking all the speakers and also all the people who, we had some sort of scientific committee, and people sent a bit a review of a paper we were thinking were kind of influential for public health and influenza. So I would like to thank all of these people, and also the people who helped me for organizing a kind of materially this little symposium. So yeah, I mean, it's time for upload.